Our next speaker is Dr. Asma Al Btoush, is Associate Professor at Medicine of University of Jordan. She is had a respiratory and sleep medicine specialty at Jordan University. The stage is yours, Dr. Asma. Welcome.
First, I would like to express my gratitude and sincere appreciation for the organizing committee for this kind invitation. I think this is very important to bring rheumatology and pulmonology together because we are now dealing with more and more interstitial lung disease on the background of connective tissue disease that is often silent and is associated with significant morbidity and mortality due to the delayed presentation. So I am here today to, it's a pleasure for me to speak about the screening guidelines for CTD-ILD. You are the expert here. I'm just sharing with you the guidelines. And also I would like to share with you a few cases from our institution. So I'll start with, this is my disclosure. So the outlines of my talk today will be a brief introduction about connective tissue disease, why screening matters, and I would like to introduce the ILD MDT at Jordan University Hospital in collaboration with our dear rheumatologist at Jordan University Hospital. And I will present some of our own research data about connective tissue disease, and then going through the guidelines by discussing case scenarios. So I would like to start with this case from our clinic, which I usually call a happy scenario. So this is a patient with systemic sclerosis who was referred from rheumatology clinic for assessment of interstitial lung disease. So our rheumatologist screened her with high-resolution CT scan and referred her to our clinic. And we found on imaging that she has, so if you look here, you can see some areas of ground glass opacification on initial presentation. So this patient has significant interstitial lung disease with no respiratory symptoms. And at presentation, her lung function, maybe the slide doesn't project well, but her lung function test showed normal FVC with mildly reduced diffusion. We initiated this patient on mycophenolate, and you can see almost complete resolution of these changes on subsequent visit. So, as you all know, that patients with autoimmune rheumatic disease or connective tissue disease are at high risk of developing interstitial lung disease, and most importantly, scleroderma and rheumatoid arthritis. And the rest of connective tissue disease are also associated with significant involvement in the lung. So I will be discussing how to screen those patients according to the latest guidelines from the European and American guidelines. So you all know that the prevalence of connective tissue disease among ILD is about 15 to 25%. In some registries, it is the most common ILD group after idiopathic pulmonary fibrosis, and there are other registries where they found that ILD due to connective tissue disease is the most common. This is unpublished work from our institution at Jordan University Hospital. We studied about 80 patients with connective tissue ILD, and we found that 14 out of the 80 had interstitial lung, has a proven connective tissue disease. We also did another study about the predictors of mortality and physiological progression in patients with connective tissue disease. We retrospectively studied 80 patients at Jordan University Hospital, and we found that the predictors of mortality are related to certain comorbidities, older age, presence of certain antibodies, and high inflammatory markers, and there are also markers related to progression and decline in lung function. As you can see here, patients who progressively decline had anti-CCP, anti-SSP, and also high ASR. So those patients are likely to progress, and they are at high risk of significant disease. So we know that the burden of connective tissue disease is related ILD is high. So it is very common in patients with systemic sclerosis, up to 40 to 80%. In some registry, it can reach up to 90%, and 20 to 40% in rheumatoid arthritis. Usually, it is associated with significant morbidity and mortality, and in rheumatoid arthritis, the estimated mortality is 30 to 40%. This is here a slide showing the survival of patients with connective tissue ILD, and you can see at 5 years, here you can see that maybe around 70% of patients with scleroderma are alive at 5 years from the diagnosis, and this is 50% at 10 years. So half of patients we see who are diagnosed with scleroderma will be alive after 10 years of follow-up. And the same apply for other diseases with mixed connective tissue, and myositis also carried a very poor prognosis. There is significant interplay between the inflammation and fibrosis in patients with connective tissue disease. So I would like here to highlight that in patients with connective tissue disease that there is an early inflammatory phase where patients are very responsive to immune suppression, and this is followed by a fibrotic phase. And we would like to catch patients at this stage. So why early screening matters? Because the prevalence of these diseases is the interstitial lung disease among these patients is high. There is asymptomatic early phase, and patients with connective tissue ILD have other manifestations that can mask respiratory symptoms, so the disease might go silent. The physiological and radiological changes that precede the clinical manifestation also can be months or years, and extent of ILD and the characterization on CT scan is very important as a prognostic factor for mortality. Also, the screening is important because we need a multidisciplinary care to improve better outcome and early therapy. I would like here to share with you 2 or 3 slides about our MDT. So you know that a multidisciplinary team discussion for interstitial lung disease in general should be, and the gold standard for diagnosis is MDT. So it is in the guidelines. So we have established our first ILD MDT with collaboration with our rheumatologist colleagues. We started 2 years ago, and we have discussed many patients. We are very happy with the progress of the MDT, and we are reaching more accurate diagnosis, and we are also having collaboration at early stage of the disease. I would like also to comment on the role of rheumatologists in MDD or MDT. So if you can look here, you can see that in patients who were labeled to have idiopathic pulmonary fibrosis or hypersensitivity pneumonitis, before discussion in MDT, the disease was changed by the input of rheumatology, and this is very important because treatment is different, and patients will improve significantly if they were treated early. So I would suggest that in every institution, try to get an MDT to improve collaboration between different specialties. I would like also to share with you a slide about the power of MDT. So this is a patient of mine who is a 52 years old lady. She presented with dyspnea and cough of 5 years duration. She has no features to suggest connective tissue disease. She has negative autoantibodies. She has bilateral ground glass opacification, as you can see on her CT scan. She has a mild impairment on her lung function test, and her echo showed diastolic dysfunction. We sent this patient to rheumatology, and before we had our MDT, and there was no evidence of connective tissue disease because she is a lady and she is relatively young. So we decided to proceed with the VATS biopsy, and again, this patient was investigated before our MDT, before the establishment of our MDT, and the biopsy came back with dyschromative interstitial pneumonia. And then we insisted on our rheumatology colleagues that we should look for a connective tissue disease, although it can, dyschromative interstitial pneumonia can occur in patients who are smokers. Again, there was no evidence of connective tissue disease. She was trialed with a steroid with no improvement. We decided to discuss her in our MDT, and we found that this patient has heart failure, and now she is having workup for HOCM. So we withdrew immune suppression slowly, and this patient now is receiving care from cardiology team. Now, early detection and treatment of CTD-ILD improves outcome. I won't be going through these studies. You may all aware that improvement in outcome and improvement in treatment for these patients is associated with early detection. These are the guidelines that I will be going through today. So I will be referring to the ERS-ULAR clinical guidelines and the ACR chest guidelines. So what are the screening tools? So if we decide to screen those patients, we should proceed with high-resolution CT scan and pulmonary function test. But we always prefer a high-resolution CT scan. We also should look for antibody profiling. And there are some studies on evolving a new modality, which is lung ultrasound, which I'll be mentioning in the coming slides. It is emerging modality, but it's not yet in the guidelines. The recommendation is against chest X-ray, 6-minute walk, ambulatory desaturation, of course, invasive procedure like bronchoscopy and surgical lung biopsy. Again, we know that symptoms and examination are associated with reduced diagnostic accuracy. So you can see the sensitivity of respiratory symptoms is very low, as well as the detection of Velcro crackles. Although there are some electronic devices that can detect Velcro crackles on auscultation that can be combined with lung function impairment where we cannot have a high-resolution CT scan done. Okay, this is a patient who is 35 years old with scleroderma over 5 years. She presented with cough and dyspnea on minimal exertion. She was unable to perform PFT because of the severe tightening of the muscle, of the skin, sorry. And this is her first high-resolution CT scan. You can see extensive fibrosis and extensive destruction of the lung parenchyma. This patient was immediately started on mycophenolate and nintedanib, but unfortunately she is slowly improving. At the time of presentation, she was also in heart failure. So in patients with pulmonary fibrosis due to scleroderma, we know that the guidelines recommend screening for all patients. So all patients with scleroderma should have a high-resolution CT scan. This is because the mortality is high and there's significant morbidity and mortality from missing those patients early. A lung ultrasound was studied in patients with scleroderma, and they found significant correlation between the high-resolution CT scan of fibrosis and certain ultrasound findings. So if you can look here, this is the normal ultrasound appearance of the lung. So the white here is the normal lung, and the rib shadow is represented in black color. So what we see, what we expect to see in patients with pulmonary fibrosis is thickening of the pleura, and also something we call B lines here. These are perpendicular lines on the pleura, and we can sometimes detect subpleural cyst. Of course, this is evolving, but it is being studied to reduce exposure to excessive radiation. So it's still not in the guidelines, so we recommend against, or the guidelines recommend against lung ultrasound for screening. This is another patient who is a 65-year-old smoker lady with seropositive rheumatoid arthritis. She was admitted through ER after recent upper respiratory tract infection for evaluation of hypoxemia. She has a normal spirometry and DLCO that is moderately reduced at 65%. So this is her initial CT X-ray. We saw some fine reticulations, and we ordered high-resolution CT scan, and this patient was found to have pulmonary fibrosis. Unfortunately, this patient was not regularly following at the rheumatology clinic. So I'm sure if we all know that the screening guidelines recommend screening such patients. I won't be discussing the pathophysiology here because I don't think we have time. The prevalence and mortality of RA-ILD is important. So it is patients with rheumatoid arthritis who have a usual interstitial pneumonia pattern on CT scan, which is suggestive of advanced fibrosis, usually have a survival of around 3 years. And this is a very interesting slide showing that patients with rheumatoid arthritis and ILD are likely to survive less and to die more. And this is a nice study showing that those patients who had their methotrexate suspended had poor survival. So if we stop methotrexate from a rheumatology point of view without knowing that these patients have interstitial lung disease, these patients are likely to deteriorate because they need immune suppression for their lung disease rather than rheumatological disease. Screening for rheumatoid arthritis in patients who are smokers, elderly, male, high titers of anti-CPAs and RF, and severe articular disease, rheumatoid nodules. And this is a new promoter gene variant that is being associated with IPF, and it's being found also in patients with rheumatoid arthritis, ILD. So it's a genetic marker that is being strongly linked to lung fibrosis in rheumatoid arthritis as well as IPF. Maybe it will be later on in the guidelines. It's still a research tool. So patients with rheumatoid arthritis with all these risk factors should be screened with high-resolution CT scan, and this is a conditional recommendation. Also, I would like to mention that patients with rheumatoid arthritis can have ILD years before the development of articular disease. So we usually follow these patients up. This is a study where they found patients with anti-CCP positivity who have ILD. They followed these patients. These patients developed rheumatoid arthritis after a year and a half, and only 9% of them developed rheumatoid arthritis after the ILD. Ultrasound also was studied in rheumatoid arthritis. Again, it has a moderate diagnostic accuracy. Some recommendations to combine it with a serum marker called KL6. Until then, we are still screening patients with high-resolution CT scan. So in rheumatoid arthritis, as you can see here, we screen patients with risk factors. Okay, this is another lady who is 55 years old with mixed connective tissue disease for 5 years. She presented first to our respiratory clinic. By the way, this patient was a resident in Canada, and she was followed by pulmonology and rheumatology at Canada. But unfortunately, they missed her lung disease, although she was coughing for 5 years. So delayed diagnosis is universal. It happens everywhere. So this patient presented first time with hypoxia. She's now on long-term oxygen therapy. She has a severe reduction in her forced vital capacity. And you can see here the extent of fibrosis has dramatically increased. So this area here represents the initial fibrosis in 2022. And you can see that it is more white and dense, indicating significant fibrosis after 3 years without treatment. So in patients with mixed connective tissue disease, so the guidelines suggest screening with high-resolution CT scan and to look for most important risk factors for progression, which are inflammatory markers and certain autoantibodies. So in the EULAR, the mixed connective tissue disease should be screened with high-resolution CT scan from the beginning, although I couldn't find exact recommendation in the American College of Rheumatology. They're still screening those with with risk factors. Regarding inflammatory myopathies, so patients with idiopathic inflammatory myopathies have significant ILD, and their ILD is dramatic. So we should screen those patients if they have the following risk factors. Again, some would screen without risk factors, and some would wait for the appearance of these, some of these risk factors. So these are the risks that we should screen for, and I believe you are the expert here. We cannot diagnose inflammatory myopathies without the presence of these, I think, clinical features. So I guess most patients with idiopathic inflammatory myopathies should be screened. Most patients without risk factor could be screened, so it was left to the physician to decide, but I believe that all of them should be screened. So here in inflammatory myopathies, if you have risk factor, you screen. If no, you still can screen. Regarding Sjogren syndrome, so the incidence of ILD is around 20%, and patients with Sjogren should be screened only if they have these risk factors, so older age, male sex, active extrapulmonary organ involvement, autoantibodies, lymphopenia, or other risk factors. There are other risk factors adopted by different guidelines, so these should be screened according to their risk factors. So in patients with Sjogren, you can screen if they have risk factors, and if they don't, I guess you don't need to screen. Regarding lupus, when they formulated the guidelines, they couldn't find any evidence on ILD in lupus and on recommendation who to screen. So they made no recommendation. They were unable to make any recommendation because of the low prevalence and lack of evidence of certain risk factors associated with ILD. So we don't know who to screen in patients with lupus, although we just published this study with our rheumatology colleagues at Jordan University Hospital about, it was a study of around 395 patients with lupus, and you can see from the numbers here that most patients have interstitial lung disease. So if you look at the ground glass opacities and atelectatic bands and fibrosis, if these collectively are termed ILD. So we have a significant ILD in patients with lupus, but we don't know who to screen. I found this paper while preparing for this talk, and I found it interesting. So this is a consensus made by physicians from the Middle East, from Emirates, Kuwait, Lebanon, where they virtually meet, and they put a what they called a summary of the questionnaire that they would like the pulmonologist to do in their clinic to detect early connective tissue ILD. So in this guideline, they suggested, they are still working on the guidelines to make sure they are approved. So they propose that patients who are initially evaluated for connective tissue disease, they will offer them screening questionnaire for symptoms of rheumatological diseases, and if they have, then they should be referred to rheumatologists. So they guided pulmonologists to early identify those patients, because I think CTD-ILD management is a shared responsibility between pulmonology and rheumatology. So we as pulmonologists, we have to detect CTD early, and rheumatologists, we would like rheumatologists to send those patients when they have ILD early. So this is another thing that we, as a pulmonologist, when we see on a scan, we insist that this patient might have CTD. It's called UIP CTD-ILD pattern, where patients have something called anterior upper lobe signs. So they have fibrosis and honeycombing at the anterior upper lobe. They have exuberant honeycombing and something called the straight edge sign. So you can draw a straight edge between the honeycomb and the normal lung. And also they have what we call four corner sign. So we have fibrosis in the anterior two corners and fibrosis in the posterior two corners. And we usually, when we see this pattern, we refer those patients to rheumatology, and we insist on finding out a connective tissue disease. And sometimes we find this, sometimes we make sure that these patients are on regular follow-up with a rheumatology. Once we detect interstitial lung disease, there are recommendations on, if there is no interstitial lung disease at initial screening, there are guidelines when to repeat. So for idiopathic myositis and scleroderma, we recommend PFT every 6 months. The guidelines recommend, while for others, they recommend variable periods from 3 to 12 months. Regarding CT scan, there is a recommendation to repeat one to 2 years, even if the initial screening is negative. And we always refer patients for multidisciplinary team in case of uncertainty. So the summary is early identification of ILD in connective tissue disease is important because it will prevent advanced fibrosis. Clinical assessment is always important with PFT serology and high resolution CT scan. Early treatment improves quality of life and improves survival. There's a recommendation from the guideline that they stated that if there is uncertainty regarding whom to screen, so always screen those patients. If you're not certain, just send them for high-resolution CT scan. And in patients with scleroderma and many patients with myositis, screening is in the guideline. However, we are not screening all patients with rheumatoid and Sjögren. Thank you.